look at our attendance today, we are drawn from both the public and the private sector. So it's going to be a very interesting and interactive session. So as we wait for our speakers to join, as I mentioned earlier, Dr. Meli is joining us from China. There's a bit of time difference there, and we have Dr. Edom joining from Ethiopia. And I can see already Team Ethiopia is very active on the chat box. So those who are joining us, please utilize the chat box, introduce yourself, tell us which organization or which country you're dialing from. So just a reminder on a few rules as we unmute, not speaking. So just use the mute button when you're not speaking. If you're on good bandwidth, then you can have your video on. It has to make the sessions interactive. I'd like to see you. Thank you, Telek Asneg, for having your video on. Thank you for the rest of the team that videos are on. It makes the sessions interactive. I can this very well. So you can use the chat to make comments. You're free to do that. And then also we have enabled subtitles on your screen as needed. If you need any assistance, maybe with translation, you can reach to the Secretariat's inbox. And the sessions are also recorded. This is very important for future. And thank you very much, Koima, Ampath, Kenya. Thank you for your consistency in the eco-sessions. So today's session objectives, we are having experienced speakers in the fields of public and private. Presentation from Dr. Elias Meli, who is the Chief Executive Officer of the Cancer Institute of Kenya, NCI Kenya, oncologist in Addis Ababa University College of Health Sciences in Tukur, Ambessa. She specialized in Department of Oncology. And as I said earlier, a good combination and hybrid of private and public. So we are just to look at how can we have public and private partnerships to improve on care delivery. And most of us, those in Kenya, we know we are currently facing the doctor strike, and it is not the same with sectors. Those who can, the private hospitals are continuing as normal, yet when the public hospitals are shutting down because the doctors are not able to, not really shutting down, but the doctors in the public sectors are not able to attend to the patients. So it's a very timely and interesting discussion we have today, and just to try and see how can the public and how can the private sectors sort of partner together to improve on cancer delivery. So Dr. Elias Meli is not very new to us. He is the CEO, as I've said, National Cancer Institute. He's a medical doctor, a clinical oncologist, and he specializes in medical and radiation oncology. So he has a huge experience in inpatient care, in research, in training and policy. Dr. Elias graduated with Bachelor of Medicine and Surgery from the Moore University in 2008, in clinical oncology and nuclear medicine from Alexandria University in Egypt in 2015. Dr. Meli holds a Master of Business Administration, MBA from Catholic University, which he attained in 2023. He also holds a Master of Public Health from Moore University, also attained in 2023. He completed his Senior Management course, SMC, and Strategic Leadership Development Program with Kenya School of Government. Elias has spent a cumulative 2 years with different National Cancer Institute designated cancer centers in the United States of America. These include Indiana University, Stanford University, University of Minnesota, University of San Diego. So he has been mentored by successful legends in oncology. We know Professor Patrick Loerer. Professor Patrick Loerer, just a minute. We know Professor Patrick. Just a minute. Okay, thank you. Thank you. Sorry, we was admitting him. So he has been mentored by Dr. Patrick Loerer, learned a lot of technical aspects from him, and also in healthcare, in health management systems. So his experience is heavily motivated by properly structured, efficient, and value-based health care financing that ensured healthcare facilities are well-resourced towards service delivery. So Charles, can you cite Dr. Melly already? Has Dr. Melly joined us?
He's not in yet.
Okay.
Yeah.
Okay, so we will wait a bit for Dr. Melly. As we said, he's joining us from China. There's a bit of time differences there. And as we wait for Dr. Melly, I'd like to introduce us to our next speaker, who is Dr. Edom. Dr. Edom is from Ethiopia. So Dr. Edom Seifi completed her undergraduate studies at Mekelle University as a medical doctor in 2012. She then served as a general practitioner at Fish Regional Hospital. She was transferred to Addis Ababa University College of Health Sciences, where she got the opportunity to join the first batch of clinical oncology residency training on March 2013. She completed her clinical oncology training from AAU, Charlotte Merkel's Academy Hospital, University of Wisharød in radiation oncology, and Oslo University Hospital, Oslo, Norway in 2017. She has been working and training in the department for 12 years and as head of the department the past 2 years and a half at the same university. Dr. Edom has great interest in female cancers like breast and gynecology cancers and spends her effort in addressing these areas, both in clinical practice, multiple research projects, and mentoring residents, master's and PhD students. Dr. Edom has won the ASCO IDEA Award in 2018 and is a co-author of Harmonized NCCN Guidelines for Africa Cancer Coalition on Cancer of a Non-Primary Hematology and the MESIS for 2019 and 2020. And also the famous ASCO vaccine for cancer patients guideline. She's also a core member of different projects as Elsie Kroner Cancer Center, National Breast Cancer Guideline, and has won NEPI Fellowship Scholarship in 2019 in NAU and was the 5th cohort fellow in 2021. So as we said, we have a very rich combination of presenters today. I'm just trying to see if Dr. Melly has already joined us. We can't wait to tell him ni hao, joining from China. Okay. Okay, so as the secretariat tried to get in touch with him, just repeat again the ground rules that you can unmute when not speaking. We encourage that you leave your video on. Thank you, David Makumi, for your video. And also Boniface Mbuki, I'm not sure if that's a, thank you, David. I'm not sure if Boniface, if that's a video or, yeah, so if the bandwidth allows, of course. And also please utilize the chat box, let us know where you are dialing from. So okay. So Dr. Melly, yes? Yes, please.
Julius is here from NCI.
Oh, Julius, how are you? Is Julius representing Dr. Melly?
He's representing NCI as we wait for Dr. Mary to join.
Okay, so because Julius is already here in the capacity of NCI, we can give you an opportunity just to greet us and as we wait for Dr. Melly. Julius, you are welcome. Yeah, so Julius, can you hear me from NCI? So we are, as we wait for Julius, the public and the private sectors, they have expertise, resources, in both sectors that can help us leverage and can help us improve on this, on the services that are given to cancer patients. And because we have Priska here, cancer survivors, maybe she can say hello to us and tell us how, if the topic today would be of interest, especially to the cancer survivors. And especially now that we are facing the doctor strike in Kenya, which is now not fair for the patients who access services at the public facilities compared to the patients who are able to access services from the private facilities. Okay. Okay, Charles, how about Dr. Edom? Has she joined us yet?
I don't know. I've not seen such a name. But
Okay,
I
I'm
don't know
seeing
whether she has joined with a different name. Maybe Dr. Edon, if you are there.
okay, so I'm seeing Priska is saying, hey Phoebe, I'm in a crowded hospital waiting room. Apologies, I can't talk. Thank you, Priska. I hope all is well. Makumi, you want to say hi to us from Faraja?
Well, thank you for the opportunity. We are so looking forward to this conversation because the intersection between the public and private sector is increasingly also becoming a bit blurred because patients move back and forth, and there's a great deal we can do together in a structured manner because we are all serving the same population. So this is a great and very, very timely conversation of engaging all players, not just also private sector, but as well charities, cancer charities, NGOs, civil society agencies. All of us definitely have to work together, but within a well-structured framework to maximize on our collective and individual abilities and resources. I submit. Thank you for the opportunity.
Very well put. Thank you very much, David Makumi. Indeed, it is an area that we really want to know, and we really want to see how they can interconnect for the benefit of the cancer patients. So I am told Dr. Meli has joined us. Dr. Meli, are you in? Okay. Thank you very much. I'm told Dr. Meli is trying to connect flights and all that. So I think the floor is open because this is the discussion. As he connects, he's trying to connect flights. So immediately he does that, he will join. So these are discussions that is of interest to us, and it's interest to our patients. So maybe we can just discuss around it that how can the public and private institutions partner to improve cancer care delivery? Maybe I can throw it out. Anyone? It's free. How in your own ways or in your own experiences, how do you think that the public and the private sectors can cooperate and can partner to improve the care for the cancer patients? So the floor is open as we wait for our experts to join. We can hear from Zainab. Sorry, Zainab is saying she can't hear anything. We had our participants from Ethiopia. I'm trying to look through the chat box. There are bits of comments in the chat box about the voice. Can you hear me? Those who are here?
Yes, we can hear you.
Thank you very much. You go first, Obulemi, Ronnie. How do you think the public and the private sectors or institutions can partner to improve the cancer care delivery for the patients? And it's not really a right or wrong answer, just in your own way. And for those of us in Kenya, we already mentioned the challenges that we are currently facing. And maybe from your insight, we can see as we wait for our experts to join.
Yeah,
and you let us know how is the name correctly spelled?
Yeah, anyway, my name's Ronnie. Especially public-private partnership is very essential, and one way we need to partner is in terms of multidisciplinary discussions, because you find most of our patients, a majority will either start in most of the patients will either start in the private setting, then later on transit in the public system. So majority have like private consultations, and because of maybe financial challenges, they transit to the public system. So I would say that there are so many ways, because even for continuity of management, we require to have that partnership. Then two, in terms of case management, there's so much that we can do, especially using the multidisciplinary approach, where we are able to share and enhance our knowledge. And then we realize that in the capacity of public healthcare systems, like in a Kenyan setting, is so much of a stretch. So if there's a way we can be able to partner in a way that, let's say like a case like for the radiotherapy patients, we find like most of the public healthcare facilities have maybe one machine to do radiotherapy. But you find in the private sector, we have maybe a maximum of like 30, 40, and it's like they have more capacity to do so. So if there's a way that we can be able to partner, let's say bring in other stakeholders to be able to cushion the common man in a way that the extra cost that is being charged, let's say if the cost is like for 3,600 in a private in a public institution, and maybe a private institution, the radiotherapy cost is going to like 6,000. The extra cost, if you can maybe seek like more partnership in that area, so that we have like a win-win situation, so that most patients, most of the patients are able to benefit. Another way is in terms of drug supply. You have erratic drug supply in a public healthcare system. So if we can be able to have like a way that the public and the private can be able to co-share the cost, so that we can be able to support patients get better access to better treatment, and have better outcomes, maybe through having programs to be able to cushion further. And then in the event that maybe the public healthcare system is not able to procure some of those agents that are a bit expensive, if we could have like them coming in, instead of patients going around the city looking for treatment, looking for the drugs, if the institutions can be able to agree to the challenge here has been the openness of the public healthcare system, and even the private partners, private players. You find that most of them are not open enough to be able to say that we have a challenge here, can we be able to partner, or can we be able to support us in this area? And then another way is how can we strengthen especially screening programs and private and public partnerships comes in handy, because if we are able to strengthen screening programs, we are able to manage the cancer adequately, because we are able to detect early and intervene at an earlier phase. So I believe through partnership and through collaboration, we are able to strengthen access, have more access programs to support cancer, get in well-wishers who can be able to support, especially the public systems that tend to be overstretched. So, because you find most private facilities have very good infrastructure, but very few clients. So maybe thinking around economies of scale, trying to scale up services and bringing in the other patients in the public system, so that they are able to have more numbers, but also maybe engage insurance companies like the public insurance, like in our case, NHIF, which is our public social insurance, to be able to push on and then maybe bring in well-wishers who can be able maybe to support the extra cost. So that's my thinking.
Thank you very much, Ronnie. You've captured the entire presentation. I think it's very important. And your presentation started rather on a sad note, that most patients would wish to start in a private facility, but because of finances, they end up in the public sectors. So how can we leverage? And I'm seeing Bistrat Demberu, your hands are up. Please proceed.
Okay, thank you, Kevi. Just to a few, hello everybody, this is Bistrat from Ethiopia. Could you hear me?
Yes, we can.
Okay, good. Just to supplement a few points from my friend who have spoken earlier regarding the public-private partnership, regarding the concerning improving the cancer care in any country. Yes, there are always, a need to partner in order to maximize and optimize cares for cancer patients, and this partnership should have to be demonstrated very well in this area. And one of the other points that I would like to mention is regarding diagnostic facilities in terms of making diagnosis for cancer patients. The public has very high limitations in imaging facilities and other molecular tests and pathological tests, diagnosis to confirm, to follow, and whatnot. So in this respect, as has been said earlier, the public facilities has limitations and problems in terms of the specific tests and diagnostic issues. For instance, if you take mammography, it's only very few public facilities that have such a diagnostic instrument. So the private will take the share in imaging and facilitating such diagnostic. Likewise, other biological and microbiological tests, pathological tests could also be done and supported. The other point probably that the public should collaborate with the private is the private institution providing chemo drugs. The public, as been said, is overstretched and overcrowded by patients looking for chemotherapy. So the privates with their facilities can handle once medication, the physicians, the clinicians or the oncologist had written the medication so that they would take those medications and they can take the chemo courses in private setups. The private has, the potential to manage and provide such chemo drugs. Has been also, I also echo the radiation therapy or radiotherapy should have to be supported. The government has very few resource and limitation in expanding to reach all the radiation therapy needs. So the private should have to come upfront in installing and providing such therapy. These are the areas where, the public should have to collaborate with the private so that the maximum care could have been delivered to patients seeking such therapy. These are a few points that I would like to supplement. Thank you for providing me the chance. Back to you, Fahmi.
Thank you very much, Bishrat. And I think you echoed very well what Ronnie has said. And the challenges still go around the overstretched public facilities. The challenges still go around the lesser diagnostic services and the drugs that are available in the public facilities. And you've said, both of you, very well, that one of the ways is to ensure that we have equitable access. So the designation of the private-public initiatives should ensure equitable, accessible, and affordable cancer care services for all segments of the population, including those who are vulnerable, those who are undeserving, those who are lesser resources. So maybe these will have the targeted interventions that you're saying to reduce disparity, because there is disparity, especially in the national, in the health financing, social health insurance and all that. So there are countries that are already trying to leverage that, but there is still a long way to go. So thank you very much for those points. And Ronnie said very well about the drugs. And of course, that was also echoed by Bishrat. So the Secretariat, I think we can go ahead with the Edom. Charles, if she's in, we can go on with the case presentation as we await. So those who have joined us, we had two presenters today, very experienced. We have Dr. Meli, who is the CEO of NCI Kenya. He's currently in China for official duties, and I think maybe changing flights is a challenge for him and the time difference, but we are hoping he joins us. And we also have Dr. Edom from Ethiopia. Charles, has Dr. Edom joined us yet?
She's having some technical challenges that I'm trying to sort out with her. So maybe we can have one more person maybe contributing to the discussion as we try to onboard her.
That's very well. So we can have one more. Let's hear from Ethiopia. They are our presenters today. How are you managing the challenges in provision of the appropriate care for the public and private partnerships? We saw several attendees from Ethiopia. Or the floor is open, not necessarily from Ethiopia. Anyone? Because again, what is also coming very strongly from the people who have spoken, there is need for innovating financial models. And I think until we leverage on that, there will still be the differences in the public and private sector. So maybe we come up with models that can help to align and ensure that the patients access, especially under the insurance cover. And also we can look at capacity building, like Bishrat has said very well. How can we promote capacity building? Maybe I can ask from the panel. How can you promote capacity building so that in the public and in the private, there is that kind of partnership and there is a leveraged capacity building? I will ask Makumi, you have been in this field for some time and your experience is known. How can we improve on capacity building and knowledge exchange between the private and the public sectors to benefit the cancer patients?
Thank you, Phoebe. I think there are models that have worked. We may not even need to reinvent the wheel, because the public and the private sector have always, there are areas that they have worked together, even if it's areas that are even outside of healthcare. So we may need to look outside of ourselves within the healthcare space to say what works in other sectors in terms of public-private collaborations, and maybe learn from that, so that we in the health sector or in the cancer space are not necessarily having to reinvent a model that has been used to, say, in agriculture, or has been used in finance, or has been used in both public, private sector, and even with academia. But more specifically, in terms of capacity building, you may also find that a lot of expertise that works in the private sector is actually the same expertise that is in the public sector, because essentially many of us almost always start in the public sector and maybe gravitate to the private sector. So I think it's a question of ensuring that that is well away, so that the capacity in private sector, the expertise may be attracted there because of the pay, is also available to the public sector. And how can that be? I think many governments, even in Africa, have specific policies about what people generally call PPP, public-private partnerships, at various levels across Africa. And I know in Kenya there is such an agency that looks at how those partnerships would benefit either knowledge exchange, knowledge transfer, exchange of skills. So I think it's very, very possible, because we are dealing with the same experts when it comes to capacity building. And this has been tried in various, even between institutions, public and private, in terms of having joint training programs or joint courses or even attachments. Sometimes you may have the infrastructure in private sector that is advanced, and you may need to allow public sector staff maybe to come and have some experiences within the private sector, and vice versa. So I think what there is can be streamlined, whatever is existing, because those conversations happen all the time. Knowledge and skills exchange happen all the time between the two sectors. Maybe we only need to harness and identify specific areas that are priority, that should be strengthened and done better. So those are my thoughts. I would also want to share, for example, with at Faraja Cancer Support Trust, we have a center. We are really a private a cancer charity, but we do have a center within a public institution. So we have and the public institution has actually provided us space at no charge within, because they appreciate the work we do in psychosocial support of patients. So they have actually given us a physical space within the hospital, within the facility, to provide the services. And our staff are very well integrated. So patients are referred to us within the facility, just like they are told, go and see a dietitian down the corridor, or go and see a counselor. They are told, okay, you need this type of service, go and see the Faraja staff who are also located within the service provision area of the public hospital. So this is a model that has worked, and our staff are constantly interacting with the staff in the public hospital. So it can be done. We only need to put our best foot forward. Thank you.
Thank you very much. Very well indeed. I am informed that our didactic presenter has joined. We already read the biodata for Dr. Elias Meli, a medical doctor, clinical oncologist, medical and radiation oncology specialist with a huge experience in patient care, research, training, and policy. Dr. Elias Meli is the CEO of the National Cancer Institute, and most of the bio had already been read. So sorry about the connectivity, Dr. Meli. You are welcome, and we are saying, anyhow, we know you're joining from China. Karibu sana. So Charles, could you please project the presentation for Dr. Meli, and also inform that Dr. Edom has also joined from Ethiopia. Thank you. Dr. Meli, are you with us, sir?
Yes, Phoebe. Good afternoon. Can you hear me?
Good afternoon. Yes, we can hear you. Good afternoon.
Yeah, we say ni hao from this end. Thank you very much for inviting me. My sincere apologies for joining late. Social media is seriously controlled in this part of the world, so it's quite a struggle before you. Nonetheless, I want to thank Tenco and Eco Africa for asking me to make this very important presentation this afternoon. I am very sure other presentations and discussions have taken place. I hope my presentation will add into that so that at the end of this meeting, we will have achieved our objectives of having our participants listen and contribute in this discussion. As rightfully introduced, I work with Ministry of Health, the National Cancer Institute of Kenya, an agency which was established by Ministry of Health specifically to lead in cancer response to reduce the burden of cancer in our country and beyond, using a multi-sectoral approach and working with everyone to make sure we reduce the burden of cancer. We do acknowledge and appreciate that it's a collaborative effort because there are many key players, there are many stakeholders and shareholders equally involved in addressing this huge burden, not only in our country, but across the globe. We know every day the burden is rising, the challenge is increasing. We should also be able to put in place mechanisms and strategies to address this challenge. And the National Cancer Institute of Kenya is that implementing agency on behalf of Ministry of Health. My presentation is going to be real quick. And we all appreciate that our topic is leveraging public-private partnerships to enhance cancer service delivery in Kenya and beyond. We all know who is public and we all know who is in private sector. It is a strategy which all sectors in our country are employing and deploying currently because we have different strengths and we have different diverse experiences and diverse resources that jointly, if we use together, we will be able to make positive progress. Now, what are the indicators that we are looking at in cancer care? When we talk about reduction, we would want to jointly, using all the efforts, make sure that the incidences of cancer reduces. Ultimately, it may increase, earlier on, but as it increases, then mortalities and morbidities should reduce. And looking at across the entire continuum of cancer care. Next slide, please. Yeah, so public and private sector. Our main goal really in Kenya, working collaboratively, is to make sure there is improved access to quality healthcare for all and cancer care specifically in this case. We talk about public-private partnerships, but there is an additional component of public-private cooperation. Cooperation is bigger than partnership because then it means you are looking at the bigger impact. So as we look at PPP, we also look at PPC. This seeks collaboration with private sector in the situations where the public health system is not immediately able to provide guarantee. And all of us knows, as I rightfully said, that the biggest challenge that we have is limited resources. And if we can leverage on our individual strengths, we can actually utilize the limited resources efficiently and be able to provide care. And if we do this, we will therefore have a superordinate goal. We will have high perceived payoff to both parties. There's going to be equal power with both parties, if not equity. And there's going to be mutual trust between the government and the private sector. Government, in this case, being public sector. Many a times, us who have invested in private sector, we would always want to know, do we have the goodwill from the public? And whenever we have the goodwill from the public, then definitely anyone would be willing to invest, anyone will be willing to partner, anyone will be willing to cooperate. This slide pretty much talks about our incidences. The recently released GlobalCan data has upscaled our incidences to 44,726 new cases, while mortalities are at 29,317, every year in Kenya. This is not good news at all. We would wish that the gap, especially at this time when diagnostics are improving, the gap should widen, where probably we should be having more incidences and less deaths, because we've also invested in, screening strategies, early diagnosis that then should improve on treatment outcomes. This is estimated data. At the National Cancer Institute of Kenya, we are working on streamlining our data, and soon we will have locally generated data that will give a true reflection of the status of cancer care in our country. So this shift in disease burden from one that was largely communicable to non-communicable condition puts strain on scarce resources in an already overstretched healthcare system. We understand that currently we are in a crisis back in Kenya because of limited resources. We cannot meet the demands of the healthcare providers, but a solution definitely is in the offing, and we are certain out of the limited resources, a solution should come out. And we are looking at resources here in terms of human resource, finances, technology, commodities, infrastructure. All that are potential opportunities where, when the resources are limited, private sector can jump in, and we can have a discussion, and have an arrangement that can certainly improve on cancer care in the country. This has happened before, and it is ongoing in some areas across the continuum of cancer care. Cancer has a significant impact on the economic growth due to the high cost of diagnosis and treatment and lost productivity as a result of cancer-related premature deaths. We all know that cancer is one of the causes of premature deaths. We all know that when one is diagnosed with cancer and undergoes treatment, they are unlikely to be productive. The economic, we have many times reiterated that when you get diagnosed with cancer, you are 1 inch away from poverty, because it drains all the resources, irrespective of, how much resources that you have. If you are diagnosed with aggressive type of cancer, in many a times, it would be very expensive to treat, especially in this era of novel molecules, which are extremely costly in terms of targeted therapies, immuno-oncology, bone marrow transplant. So all those are opportunities of potential partnership to avert such a crisis whenever, whenever one is diagnosed with cancer. We have had partnerships with private hospitals that have services that we do not have. for instance, bone marrow transplant, radiosurgery, diagnostics which would ordinarily be expensive, at molecular characterization. And we've also had partnership with private sector in pharmaceutical through access programs to make sure our patients are able to receive these drugs in affordable costs. And many such access programs are existing. And these are results of public-private partnerships. It is public health concern, and the health system needs to be prepared to meet this emerging threat. Specifically, marked inequalities exist in availability and readiness within the health system, both in the regional and county facilities to provide services across the cancer care spectrum. This afternoon, I have been in a meeting where our main topic of discussion was Health Without Borders, where we are asking how can we use innovation to provide equity. We live in a world where there is a lot of inequities across board, and looking at cancer care, in high income countries have different outcomes compared to low income countries. The burden is higher in low income countries, it's less in high income countries. What is it that we need to do and work jointly, both in public and private sector, government, non-governmental, state, non-state, to make sure that our partnerships are able to provide equity across the country, across the world, where then no one should suffer the risk of poor outcomes by virtue of where you are born, race, gender, religion. We should be able, in the long run, find ways of collaborating and partnering, internationally and internally to make sure that these inequities are addressed. Next slide, please. Yeah, quickly through this slide, we all recognize that in Kenya, breast, cervical cancer of the esophagus, prostate, and colorectal are among the common cancers. And cancer of the esophagus is likely to kill you within 1 year more than any other cancer because of nutritional complications. And in children, we must acknowledge that leukemias, lymphomas, retinoblastomas, and nephroblastomas are the leading types of cancers. And more women are diagnosed with cancer, and more women are likely to die from cancer compared to men as well. So these are the inequities that we need to get into the depth of the matter, working with in collaboration where capacity in public sector is not present. Sometimes also the reverse is true. In private sector, they might not have as much capacity as in public. Case that I can reference directly, public sector always have a lot more trained healthcare providers than private sector facilities in areas of service delivery. And therefore, a lot of private institutions are staffed by healthcare providers who work in public institutions. So it is a win-win situation where we have PPP with regard to service provision. But there are other public-private collaborations that may not necessarily have shared resources among healthcare workers, for example, in pharma industry or in financing institutions, among many others. Next slide, please. Yeah, so next slide. I think I've alluded to that. Next slide, please. So in our country, there has been a lot of progress in investing in capacity for the country to provide, comprehensive cancer treatment. We have 12 comprehensive cancer treatment centers, 6 of which are in public sector and 6 are in private sector. And this is a clear demonstration. All these centers, both in public and private, are treating Kenyan citizens. The private sector is providing additional resources which would otherwise strain the public sector. And our government has appreciated that to an extent that in healthcare financing reimbursement, both public and private sector are considered. So it is a clear indication that if you went to a private hospital, you will still get reimbursement from a government institution for patients they provide care at the same rate as those which are in public. And unfortunately, if the private institution costs quite higher, then you may have to top up. But already a lot of patients who are waiting to receive treatment in these cancer treatment centers, whether surgery, whether radiation, or whether systemic treatment, chemotherapy, targeted therapies, and all the other immuno-oncology and all the other possible systemic treatments are reimbursable to all these facilities. And this is quite good progress. We probably need to just enhance it. If I walk into the corridors of some of our private institutions, more often than not, they have less queues compared to public institutions where patients still have to wait for 1 or 2 months, or even more than that, whenever we have challenges with technical issues amongst these machines. Next slide, please. Yeah, so we really have to work together, and it is important to appreciate that there are different areas of possible partnerships and collaboration between public and private sector. We know we are shifting our approach of healthcare in our country as we embrace universal health coverage towards primary healthcare and community diagnosis, community treatment, and community health promoters, who are our level 1 healthcare providers, provided now for by the legislations that we passed recently as a country. They are domiciled in the community. They are and will continue to play a very important role. So there is different ways that we've been able to partner in capacitating these community health promoters to make sure they have adequate knowledge at their level of education to meet the objectives of their deployment to serve in the community across different areas of health promotion and prevention of different risk factors, not only for cancer, but also for other challenges. Patients who present with cancer would present patients would be diagnosed with cancer would present indirectly. Therefore, it is important to educate our community health promoters to suspect and be able to link patients to level 2, level 3, level 4, 5, and 6, where additional investigations will be provided, and patients should be able to get the right diagnosis and get the right treatment. There are also potential areas, and I want to appreciate NGOs have played a very big role in this area, working with community health promoters. Whether it's USAID, whether it's AMREF, whether it is individual NGOs that have been, some of them are actually members of KENCO, and they have been able to support in doing different trainings in different populations across the country. That is a clear show of how a private-public partnership can work. We also have to invest in healthcare infrastructure. At this point in time, there's still a lot of challenges in our healthcare infrastructure. We have made progress though, but there's more desire to be done. And we have had private institutions providing placements of equipment. And what we have had to do as government is just to purchase reagents to make sure that these patients get the requisite investigations, mainly in pathology. I can reference some companies like Roche, BD, we have AstraZeneca, we have MSD. These are companies that, and I have not exhausted the list, it is very long, that they have invested in placing equipment. And ultimately, all that we need to do is to purchase the reagents. It's a form of public-private partnerships. And we have to make sure services is delivered. Once we have that collaboration, it is going to be either community services, primary care, or oncology services. We must appreciate that research and development is the wheel that drives innovation currently. This is an area also that we have a huge opportunity of partnering with different institutions to make sure that we are able to treat our patients through evidence-based guidelines and practices. And we have partnered with many institutions on this end, locally and internationally. Next slide, please. Yeah, I'm almost done. Now, again, if you look at partnerships to address this burden that we have in our country, we have really had our focus in the 4 components of cancer control, which is prevention, early detection, diagnosis, treatment, and palliative care. And NCIK has been planning cancer prevention and control awareness through information, education, communication channels, including media, which is also another very important partner that has given us an opportunity to inform, to communicate, and also entertain the public so that they can be able to understand and appreciate and be, more empowered. We are looking through a very strong partnership that we have with one of the pharmaceutical companies to address the care across the entire continuum by looking at patient empowerment. We are also looking at capacity building for healthcare providers, and we are also looking at investment in infrastructure for accurate diagnosis, as well as access to medicines. As I had alluded earlier on, they are very expensive drugs. Without an access program, it cannot be affordable in our country at this time. There are also institutions that have partnered with us in patient navigation to make sure that we have our patients understand what is their next course of action. And we have worked closely to make sure that through our website at the National Cancer Institute of Kenya, we have one single source of truth where patients can get to know, what information would they like about a particular challenge that they have. So partnerships with private and public sector, counties, high-income countries, collaborations with universities, advocacy groups, civil society, academic institutions, pharmaceutical members of political class. We all must work together to make sure that we address this challenge, and all our arrows should point forward. Next slide, please. As I bring this to a conclusion. So then it is critical that there is government commitment and goodwill from partners, and private sector play a pivotal role in advancing, cancer care training and research in our country. They support vital activities, and they pioneer stronger patient care solutions. And it is true that what we desire ultimately is the impact, which is reduction in the burden of cancer. As we continue investing in it, we are seeing good outputs and outcomes on the resources that we've jointly invested, both in public and private and jointly. And the last slide, please. So there are opportunities for continued collaborations. We need to identify where there are areas that are gaps and how each one of us can plug in and be able to provide additions. I have always appreciated the private sector. Many a times we would look at private sector as profit-making interested entities, but I have acknowledged and recognized that some of these institutions are no longer looking at profits. They are beyond that. They are looking at impact. We've had discussions today with major institutions, including Bill and Melinda Gates, that we all know are supportive of a lot of humanitarian activities, including healthcare initiatives, people who have resources that they are willing to deploy as support systems and mechanisms. That is just one of them. We know many other philanthropic institutions and individuals that are supporting our healthcare initiatives. We have to make sure we are synergistic and we reduce duplication, and out of this be able to resource mobilize so that we can adequately address our challenges. And we have a ladder that we should all be willing to climb. And these are areas that I'd mentioned that potentially we would have to appreciate. And this includes training, investing in our regional cancer treatment centers, training and education, and then research and publication, among many other possible available avenues that public and private sector can partner. Thank you very much. I would be happy to continue listening, and if there are any questions, I will be happy to take them.
Thank you very much, Dr. Nelly. Dr. Meli, that was very elaborate. And of course, we all appreciate the role that NCI Kenya continues to play in oversight and regulation of cancer prevention and control in the country. So I hope we have seen the opportunities of collaboration, and thank you for bringing very clearly the public-private cooperation, which is better than the public-private partnership. So I'm seeing a hand by Gaudentia and Priska. Could you ask, we could start with Gaudentia as we prepare for our case presenter, Dr. Edom, oncologist from Ethiopia. Gaudentia, you have a question for Dr. Meli, please?
Hello, Phoebe.
Yes.
Yeah, I had posted a question on the chat, so I don't know whether you have seen it.
Yeah, so I can read the question. The question says, how can we package cancer awareness and screening in a way that it can cover the primary, that it can cover. Okay, could you just read it?
Okay, I will. Yes.
Thank you. Please go ahead, Gaudentia.
Yeah, okay. More often we get cancer awareness. So how can we package cancer awareness and screening in a way that it can cover the primary interventions and early diagnosis for those patients with, for example, if we do breast cancer screening, we can find a patient with a lump, or when we do cervical screening, we can get a patient with a lesion. So when it comes to maybe confirming diagnosis, the processes, so that we can maybe do minor surgeries, to reach diagnosis has been a challenge. And from the experience, I've realized that some patients who are discovered at the primary stage during cancer awareness, when they go home, maybe they think about the expenses and they sit back. Later on, they are brought back to the facility just to realize that they're already in the advanced stage, yet they were suspected early enough. So how can we package the cancer awareness month so that those identified with at the primary level, they can access care, diagnosis early enough to prompt to lead in prompt intervention.
Okay, thank you. Dr. Melly, you could just hold on to that. She wants to know how we can close the gap between early screening and this treatment. So I think that will be patient navigation that will come very strongly. We can pick the question from Priska and then we allow Dr. Melly to handle them as we usher in the next speaker. Priska, your hand was up, please.
So
Okay.
Priska said she was clapping. He was appreciating the presentation. So Gaudentia, thank you for your question. It's been a concern of many patients. We know the previous healthcare financing had limitations. And in our country, as we all know, that there are a lot of healthcare reforms and a lot of legislations have come into place recently to address the burden, of healthcare in general. And remember, universal health coverage is one of the priorities of our current government. It is one of the bottom-up economic transformation agenda priorities. And in order to realize this, Ministry of Health has adopted 4 priorities which aligns to the government priorities. Number 1 is healthcare financing. Number 2 is human resource for health. Number 3 is availability of health products and technologies through many other ways, including manufacturing locally. And number 4 is digitization to make sure there is efficiency and there is cost cutting and accountability and integrity in our system. So healthcare financing has been addressed through Social Health Authority that now provides for 3 funds: primary healthcare fund that will pay for all the primary healthcare related costs for cancer. These cases include screening for the 4 major different types of cancers, and also if a patient has a lump, a mass, a lesion, or symptoms that are suggestive, it requires additional investigations through imaging and radiology or pathology. They would all be covered now through Social Health Insurance Fund, which is the second fund. And for those who will exhaust that fund after treatment, whether it's surgery, systemic treatment, or radiotherapy, additionally, they will be able to get covered by critical emergency and chronic disease fund, which is a third fund. So issues of financing for healthcare, I think there's not going to be any iniquities in that. As long as there is availability of funds, I think the requisite legislations and institutions have addressed that challenge. Yeah, so I want to believe that answers Gaudensia's question. So beginning as promised by our ministry, beginning the next financial year, when new registration is done for everyone, then this will solve the challenge. However, currently, in the remaining months before that, before Social Health Authority takes off officially, we still have that limitation of cost. And what we are asking our patients is, even with your regular current IF card, there is still provision to be supported in some institutions and some patients below. And where they cannot, we are asking them to mobilize resources, but this is not going to be a challenge that will last beyond the next 3 months.
Okay, thank you very much, Dr. Melly. And of course, the healthcare financing is a huge thing right now. And in your previous presentation, you also noted that the government is working towards closing the gap that is currently going on with the healthcare providers. And of course, because the public doctors are not available in the facilities, it could also cause the delay between early diagnosis and the actual inception of treatment. So our next presenter, as we said earlier, we already read the bios. Dr. Edom, sorry for the technical hitch. Dr. Edom Seife is a clinical oncologist from Addis Ababa University College of Health Sciences, Tikur Ambessa Specialized Hospital, Department of Oncology. So she's going to give us a case presentation today on our topic, which is service delivery, how to capitalize on public-private partnerships to strengthen public sector cancer care service delivery. You are welcome, Dr. Edom, and here we say in Ethiopian language, salam. Charles, are you able to project the presentations for Dr. Edom? Okay, so as the Secretariat prepares the presentation for Dr. Edom, and as we just ensure that she's on set, if there's any other question or any other area, you can feel free to type it. We have the CEO of NCI Kenya with us today. So if you have any question or anything that you, or a point that you need to add up to that, I think he has mentioned very many of concern and of notice to us was the areas of collaboration in prevention, infrastructure, service delivery, training, research and technology, also opportunities also in collaborations, resource mobilizations that exist for successful public-private partnerships to benefit the cancer patient. So as we look at the chat box, I am seeing John Black. Please, your hands are up. Please go ahead.
Yes, can you hear me?
Yes, we can.
Great. So, Dr. Meli, thanks for the broad, comprehensive discussion. My name is John Black. I'm from Uganda. I work at the Uganda Cancer Institute. And I'm also involved in digital health research. What I was hoping to hear more from this discussion, and maybe you can comment on this, is how do we incentivize the public sector to invest in cancer care? And I'm asking this because several issues that I've observed, but maybe this is the Ugandan context. One is that cancer care is, in general, I don't think it is as lucrative as a good business as other healthcare issues, because first of all, you tend to have fewer patients compared to, let's say, people who get malaria. And two, you tend to have people who, the other thing is that healthcare is expensive, cancer care is quite expensive. So you can only milk so much money out of the patients before they actually run out of money. When you have things that are cheaper, so it's like, buying a car versus buying, I don't know, a snack. You can buy so many of those and you can have even children afford them. So when you have something that is as expensive as cancer care and few people can afford, the private sector will tend to shy away from that because they don't get their money back as quickly. That's what I'm thinking if I was to be, starting up a health facility. But the other is that they actually cannot afford to set up facilities. I mean, there are some good private facilities, but those are big, high-end, huge investments. But we also want to do cancer control really in the primary level. We want to have people participate in screening and vaccination and awareness at the very primary healthcare level, because that's where there is, the majority of the people, for example, investing in laboratories for diagnosis. So how do we get the private sector incentivized? How do we show that it is a good business for them to invest? Because otherwise they just go to where it is more lucrative. I want to hear your thoughts about this, and maybe not only Dr. Mary, but maybe others can mention something to this issue. Over.
Thank you very much, John Black. I think the question is clear and the floor is open. Dr. Meli, you can go, or anyone who would like to give more insight on John Black's question.
Well, interestingly, different environments provide different opportunities. I would respond in confidence that there is a lot of business privileges that an investor would see in investing in cancer care. In our country, as we speak right now, we have more than 100 cancer treatment centers. And if you see investors who are both businessmen and healthcare providers, they are largely healthcare providers opening up these centers. When there is circulation of resources, when there is confidence that payments will be offered, there could be few patients diagnosed with cancer, but the cost of cancer care is quite expensive. If I am to treat 10 patients who have cancer, and my primary goal is how much, profits do I make? Though in healthcare, I would hate to look at my indicators of performance in profit, but rather look at indicators of performance in disease prevention and control. But the reality is, for sustainability of the service delivery, you must look at the numbers to make sure you are able to pay your bills and you are able to provide quality care for patients. So in our country, where we have a fairly streamlined reimbursement from National Hospital Insurance Fund, which is now defunct, we know that many centers mushroomed across the country, not only in cancer, when they realize there is reliable reimbursement through NHIF. So to me, I wouldn't want to look at investment in cancer care as lucrative or not, but I would like to look at it as, are you able to solve a problem? Are you able to invest your resources and across the continuum of care, be useful, in preventing, be useful in early detection, quality proper diagnosis and treatment and follow-up, and all the other support services that would be available. So how do we incentivize public sector to invest, in it? Public sector runs on taxpayers' money. It then requires institutions to lobby, our parliaments and our national assemblies to invest more in cancer care. And most of our legislators are very ignorant of what happens, in day-to-day service delivery, unless one of them becomes sick. So it has to be very intentional that we have to hold meetings from time to time. We've been able, through National Cancer Institute of Kenya, lobby and additional resources. Our budget has never been the same since NCI was established. Every year it is increasing, and we hope it can hop and jump soon so that more resources can come in from taxpayers, as we also work to strongly partner with private sector to also invest. They have a corporate social responsibility as well, and we have seen their goodwill working with them. So it is all about, is there going to be reliable reimbursement? And that is how then people will be motivated. I would, with confidence, again, confirm to our colleague from Uganda Cancer Institute. In Kenya, we have so many cancer treatment centers, and a lot of these centers, I know they attempt to solve an access gap, but they have the confidence also that if we invest, we're going to get returns on our investment, because there is a fairly organized insurance system that supports and pays back, though it has some challenges that will now be streamlined by the new outfit. Thank you.
Thank you very much, Dr. Meli. Indeed, it is a win-win situation. I'd like to, as we wait for Dr. Edo, maybe we can have a feedback from Nigeria. I'm seeing we have Muktasar Mustafa from the First Ladies Against Cancer, FLAC in Nigeria. How is your National Health Insurance Fund, and how are you able to help with the inequities in cancer healthcare? Maybe you can give us an insight on that, Muktasar. Or any other African country apart from Uganda and Kenya. Just how is your National Hospital Insurance Fund, and how is it favoring the cancer patients? How is it addressing some of the inequalities that we have seen in the presentation, a very elaborate presentation by Dr. Meli? You are free to type, you're free to lift your hands. We are just concluding. Okay. Okay, seems that there is no other question. So the Secretariat is going to share the presentation by Dr. Edom. It's a very elaborate case presentation. She was going to look at challenges in provision of appropriate care in the context of Ethiopia and how they're addressing the public-private partnerships to leverage through those challenges. She was also looking at how public and private institutions are partnering to improve cancer service delivery. So we are going to share that presentation with us, and we hope that we get another opportunity where Dr. Edom will come and let us know more about this. As I said earlier, she was a case presenter today from from Addis Ababa University College of Health Sciences in Takur, Mbesa, and their hospital is specialized in their department is oncology, and she's a clinical oncologist. So thank you very much for your attendance today. I'd like to move over to the next agenda and pass it on to the Secretariat for updates and announcements. And once more, just do a clap for our presenter, Dr. Meli, for coming out very strongly. Sorry about the jet lag and the journey. Enjoy China. Just do a clap, our participants, and appreciate our presenter for today. Thank you very much.
So thank you, Phoebe, and thank you, Dr. Meli, for that. Apologies again. Dr. Edom was not able to join us. She has been on and off because of connectivity issues. But like Phoebe mentioned, we are going to share the presentation as we share the presentation by Dr. Meli, and also the recording for this session. So thank you very much for joining us. So our next session will be held on April 18th, and we are going to be looking at a topic around health workforce. So we are going to be sharing the agenda as time goes by, and we look forward to you joining us again as we continue sharing on this platform. So thank you so much, and enjoy a good rest of your day. Bye.
Bye, and thank you very much.
Bye.